Welcome, everyone. We've now been joined by all our speakers and panelists. Thank you so much for joining in. This is the fifth installation of the AMR webinar series that's being hosted by React Africa. My name is Mwitupa Makashini. I'm a research associate at React Africa, and I'll just introduce our moderator for the day. So, Dr. Sharon Paul is a public health physician based in Geneva, Switzerland, with expertise in M&D, project management, and epidemiology. She is currently working as a consultant with the South Center and an adjunct faculty member at the College of Public Health, Kent State University in Ohio. So for all the speakers' full bios, you can find them. I've posted them as a PDF in the chat. And Dr. Sharon Paul also happens to be our M&D person here at React Africa. So really glad to have everybody join in, and she will introduce the speakers and panelists as they come on.
Thank you, Mitupa, for those kind words, and welcome to today's webinar on financing AMR interventions from pledges to resources. As we all know, AMR is one of the greatest global health and development challenges of our time, yet the real bottleneck is not political will or technical strategies. We have many of those. It is financing. The draft revised Global Action Plan on AMR itself acknowledges this persistent gap. While more than 170 countries have developed national action plans, only about 1 in 10 report dedicated domestic funding, and most of these are high-income countries. In Africa and other low and middle-income regions, plans often remain underfunded, donor-dependent, and fragile. The track survey shows clearly that strategies without costed budgets and secured allocations cannot be implemented. Sectors like environment and agri-food, so central to AMR, remain especially underfunded. And with declining donor flows, debt pressures, and competing health priorities, Africa faces a triple funding crisis despite carrying a disproportionate AMR burden. Now, why does this matter? Because the cost of inaction is staggering. An estimated USD 443 billion annually in lower workforce participation and productivity losses, and total expenses to treat resistant bacterial infections alone reaching a USD of 412 billion annually up to 2035. But timely investment in infection prevention control, WASH, vaccination, and new antimicrobials, coupled with appropriate use and disposal practices, could avert over 110 million deaths and generate nearly a USD of 1 trillion in economic gains between 2025 and 2050. Additionally, a 30% reduction in antimicrobial use in livestock within 5 years could add a USD of 120 billion to global GDP. So today's discussion is crucial. We need to ask, how do we close the financing gap? Is it by mobilizing domestic resources, innovative financing models, and by ensuring accountability so that the AMR action moves from being planned to being delivered? So to address this issue, today we are joined by a distinguished set of experts who have long experience in working in the field of AMR. And before introducing the speakers, let me just introduce the format. We have a 15 minutes presentation by our main speaker, following which we will be taking questions addressing to the main speaker, after which we will move on to the panel discussion where our three distinguished experts will share their perspectives, insights, and experiences on this critical topic. With that in place, let me introduce our main speaker. We have Dr. Muhammad Shafi Koya. He is the medical officer for AMR and IPC at the WHO Regional Office for Eastern Mediterranean, providing strategic leadership and support for AMR activities. He will be giving a brief overview based on the title itself, that is Financing AMR Interventions from Pledges to Resources. Over to you, Dr. Shafi.
Thank you so much, Dr. Sharon, for the introduction, and thank you so much to React Africa for organizing these seminars as part of your anniversary celebrations, and also being a partner for WHO EMRO particularly. I would like to acknowledge the existing partnership between the WHO EMRO office and React Africa in supporting our member states. So let me share my slides. Okay, I believe slides are in order. So again, as Dr. Sharon mentioned, I work with the AMR and IPC unit. Now it's the AMR, IPC, and One Health unit at the WHO Eastern Mediterranean region. We cover 22 countries, including several North African countries. And then we also have very high income countries from the Gulf region, and besides besides 11 low middle income countries in the region. And one of the important thing that we would like to mention here is that we have almost 9 to 10 countries at every point of time which are classified as fragile and conflict situations by the World Bank. So again, as a disclaimer, this is for the content of the slides does not reflect official positions of WHO unless it is explicitly stated. So Dr. Sharon mentioned about the National Action Plan funding status. This is from the same tracking of AMR program implementation across countries by the quadripartite agencies which track the information based on country self-reports. You can see a lot in yellow, which is very progressive, I would say. But then we have very few countries which are actually in dark green or light green, which indicates the countries have costed and budgeted, funded national action plans, or AMR is integrated into existing budgets and policies. So there's a lot of gap between what is being planned and being implemented. If you look at the situation across the regions of the WHO, again from the 2024 tracks data, which is again country self-reported, you will see there are differences between regions. And that's a very interesting thing to notice. The number of countries which has costed and budgeted operational plans and monitoring mechanisms in place. There is a lot to cheer for African region because there's a lot of progress, and I am sure I would attribute a lot of this progress to efforts by institutions and organizations like REACT over the last several years. In terms of progress, this is the data from the last 3 years of tracks survey. If you see the overall picture in the global status, there is not much of a difference. This almost stagnant. But there has been some there has been substantial progress, I would say, in the African region, which actually balance the number of countries where there is deficits in funding in some regions of the world. We have been talking about funding AMR programs, and the last year, the UN General Assembly high-level meeting put up a lot of very ambitious targets. Of course, the initial targets were much more ambitious, but we know that many of the targets in the non-human health sectors were watered down after the negotiations and discussions. So it is very clear when you look at the non-human health sector target, for example, it's a bit of vague without very clear targets or numbers attached to the objectives. And we know very well that non-human health sector where vast majority of the antibiotics or antimicrobials are used, where there's a lot of things to be done in terms of improving the appropriate use of antibiotics is required. I think once when we do not have clear targets attached to the global the framework of investment, it actually is a bit counterproductive when it comes to investment at the country level. We also know about the UN high-level meeting calling for sustainable national financing, including a catalytic funding of $100 million. I don't know how much is it helpful in terms of funding national action plans. It's such a very small amount of funds that we are talking about here. But the target is to have at least 60% countries having funded national action plans by the end of the decade. Um, so it highlights the need for diversifying funding sources and more contributors to the multi-partner trust fund, which is a key vertical or standalone funding source for national action plans. Of course, we all realize the threat of AMR. We'll not need to reinforce that understanding, but we also know that there's a lot of fragmentation in financing. There are a few things. I mean, the next few slides, I will be discussing a few things which can be considered for improving the financing mechanisms. One is leveraging the existing mechanisms. For example, there are, as the UN high-level meeting mentioned and emphasized, existing funding mechanisms like the Global Fund programs, the Pandemic Fund, and Gavi. We know we have challenges in all these areas in the recent period, but still these are fundamentally programs which are still existing and have opportunities to include antimicrobial resistant related activities into the model. Another way of doing it is, of course, by adapting the funding for AMR at the global level, where, for example, pooled funding wherever possible, where there are countries which share common interest, or even within the countries, regions coming together and pooling funding, and also depending on the capacity of the countries to have tiered contribution systems. There's a lot of gap in the institutional coordination. Of course, there has been some improvements, but there's a lot of institutional coordination further required between WHO, the World Bank, and the regional banks. There has been interest recently, I would say, at the regional level, regional banks level, for investing in AMR. Of course, the World Bank has opportunities to invest in AMR, but the way countries see those investments, how they perceive those investments is a critical question. Of course, dedicated funding for AMR, which at the moment, globally, the one dedicated financing mechanism is the multi-partner trust fund. That's the biggest, at least I would say. So multi-partner trust fund, as you know, it's not just for AMR. There are several active funds. There are several funds for different programs, not just for health-related programs. So it has a sizable amount of fund that we are talking about. And in terms of MPTF, which is a multi-partner trust fund, there's a huge, I mean, this is fairly better now. If you see the figures now, it's 34 million commitment and 32 million deposits at the around this time last year, where there was a bit of uncertainty. That was like really not a very good picture. And that's the time when we were planning to encourage countries to apply. But now, at least, this is how it looks like. And we know that there's currently the application process for the next cycle is almost getting finished. The proposals are being reviewed by the quadripartite agencies. Very few countries contribute to the multi-partner trust fund for AMR. So one of the things that is required is to have more contributions, more countries and institutions probably contributing to multi-partner trust fund for AMR. I will not go into the details on it. When we speak about investing and mobilizing resources for AMR, it is not just for implementing national action plans. Of course, it is important. But we also know the determinants of AMR. We know the bigger space we are talking about in terms of the biggest amount of fund that we have to go into is not just developing new antibiotics, but also making sure that existing antibiotics are equitably available across countries and regions. So there has been a lot of experiments and efforts and initiatives globally, and we have seen examples during COVID, both push incentives and pull incentives which might yield results. But when we also know that in terms of antibiotics, particularly, one of the challenge is the low time, the very limited time period that probably that antibiotic is going to work, and within which the investors have to get the return of investment. So there is always a crisis in terms of finding massive investment in terms of antimicrobial drug development compared to the rest of the categories of medicines. So there is that is why there has been a lot of initiatives in having innovative mechanisms like subscription models, for example, in the UK, for cefiderocol and ceftazidime, which were the two molecules which were part of their initial subscription model, which they started 5 years ago. The US, in case of US, a similar one, the Pasture Act is still not passed, so it is still not still in the proposal stage. We also know that in terms of development of antimicrobial drugs, one of the things, as I mentioned in the previous slide, is that it's a long process, it's a long duration of time that is required to have start that one final molecule to come out of a series of trials, and then once it has to start generating income, it takes another 5 to 10 years to get the return from a financial from a profit perspective. So we need to have multiple players in doing investment at different stages of development. So, for example, the initial stage, we cannot expect commercial entities to invest so much unless they find that there's a promising molecule which is or at least past 50% of the stage of development. So initially, so that is why we have models like where we see investment coming from philanthropies and non-profit entities in the initial phase of development of a drug. Later on, it can be for-profit entities, which when they are sure that there is going to be a drug coming out in the next phase. So the blended financing is another way of resource mobilization. We need to learn lessons from the past. We had learned both positive and negative things, for example, during COVID. We also very clearly understood the importance of having clear governance and incentives clearly earmarked and transparent communications from both HIV, TB, and also from the recent experiences from COVID-19. Public-private partnership is essential. And a public-private partnership, a private sector, which includes for-profit and not-for-profit philanthropies, it's very important. But again, it's very important to have clear roles and governance framework and incentives, which will lead to more transparency and accountability and mutual trust. Again, one of the key things I would like to emphasize is it's not just about development of drugs, right? It is about development of strategies and interventions, including behavioral change interventions, implementation science, where we have very large number of successful models nowadays coming out from different part of the world, including by supported by ICARs and other institutions. So the key thing in such learning is that we need to have pilot projects which are systematically, scientifically developed and implemented, which undergoes thorough evaluation before scaling up, so that we are sure about the sustainability and the effectiveness of the interventions before we scale it up. I think this is one area where there's a lot of work is still pending. Completing with the accountability framework, I think one of the key things is bringing together stakeholders in a very transparent, in a very public accountability framework with clear dashboards and monitoring bodies which can independently share information and transfer information. And for private sector to invest and even for other entities to invest, we need to have the funding linked to clear performance. And then civil society and media needs to have an important role in ensuring accountability. And we have seen this very, very successful, for example, in HIV and TB. So I think this is something which AMR space also should be clearly watching. Regional alignment is required to avoid waste and duplication. We have time and again, we have seen this happening even within the same country, within the same Ministry of Health, two different institutions within the Ministry of Health investing in the same sort of training, for example. And monitoring and evaluation is another area where there's a lot of duplication happening. For example, if there are programs which are already having very structured monitoring programs in place, it is just a matter of piggybacking on such programs to ensure that AMR related monitoring and evaluation programs happens in the field. So I think there's a lot to learn to avoid duplication, piggybacking on existing programs, and bringing together institutions regional, which again I would say Africa is showing the way that there's a lot of harmonization recently happening, including last week we have seen that happening in, for example, health emergencies field, where there's the countries from the Africa and the Eastern Mediterranean region came together for cross collaboration. So I think that is very effective, which brings in more bargaining power to the table, and we also will bring in efficiencies with mechanisms including pooled procurements for commodities. Um, Again, finally, we have to ensure sustainability in the long run. So we need to have a milestone which actually leads to a sustainable national level financing. For that, I think, of course, this is very difficult to implement, but I think the way to do that is to ensure AMR is clearly identified as a health system issue. Clearly identifying it as AMR is nothing but preventing and diagnosing and treating infections on time. So I think that integration of AMR into the bigger UHC and clearly identifying the determinants, including water sanitation and hygiene, immunization and infection prevention awareness, I think that is very critical to make sure that ultimately this gets integrated into the health systems. Thank you so much for your listening, and that's the end of my presentation.
Thank you, Dr. Shafi, for giving that brief overview about various funding mechanisms, accountability, and sustainability mechanisms. This will be the time to, if you have any questions to Dr. Shafi, please post it here, either in the chat box or in the Q&A box, because Dr. Shafi won't be there for the entire session. So while we are waiting for questions to come in, let me ask you, Dr. Shafi, one question. So, from your experience, what will you pinpoint as the one main obstacle when it comes to mobilizing funds in LMICs for AMR?
Um, Thank you. I think that's, I mean, this question has come up even recently in some of the discussions when we are trying to mobilize support or interest within ministries of health to do their costing and budgeting. So if I reflect a little on that, of course, we now have a WHO costing tool for costing of National Action Plan, but when we say AMR interventions, we very clearly we know that it's not just having a set of actions which is related to, say, having some structures or having a monitoring evaluation plan. It's a big, we are speaking about a wide variety of interventions, as I mentioned, from prevention, awareness to immunization to water sanitation. These are all important critical elements in determining how we progress in terms of achieving our goals in AMR. So now the critical question is how you delineate them in a way which is very clear and transparent to an administrator at the country's Ministry of Health or a Minister of Health who needs to prioritize AMR among hundreds of other things. So I think one of the things that as a responsibility for us, all of us in this meeting and all of us in this space, is to do a bit more work in this area to identify. I mean, there's a lot happening. I acknowledge that, but we need to do a bit more work in this area to say, okay, AMR has a lot of determinants, and we know water, sanitation, hygiene, immunization, everything comes into to be accounted. So what is happening in this space? What is the budget space that we are talking about? What is the investment we are looking into that? Because water, sanitation, and hygiene and immunization are not just for AMR, it's bigger common public good. So are they already being secured? So how do you account for that funding which is happening into the space? Because we need also our political leadership also wants to see what's the result that is coming out. Of course, we have calculations of return of investment. So maybe we have to do a bit more work from institutions like ours to make it clear, like, okay, besides all those investments that is happening in the bigger determinant space, what is the exclusive funding that we are expecting from the minister or Ministry of Health or Finance to put in place to make sure that that integral core components of AMR programs are in place. For example, how the national structure is in place and how they are funded and supported to do monitoring and evaluation, for example, and coordination between sectors. I think that is a fundamental thing that we need to reflect ourselves and maybe do a bit more homework.
So essentially, the challenge is how to develop a case around financing AMR itself. So let's again wait for some more time for more questions to come in. So piggybacking on the what you have just said, uh, from where you are sitting, like you already mentioned that part of your work involves geopolitically fragile areas as well, and there are other priorities, pressing priorities that come into place. So in from that context, how do you develop a case specific for AMR financing? I hope I am not complicating the
No, no, I think that's again an excellent question. Again, we have been trying to do some things in this space. One, I will start with something which is still a big gap is I mentioned about pandemic fund, for example. Pandemic fund, many countries, especially countries from Africa, has demonstrated clearly the utility of pandemic fund as an opportunity to mobilize resources for AMR. But unfortunately, in most of the regions, most of the countries, when they put pandemic fund proposal, for example, do not have an explicit component of AMR, although AMR is a potential area for mobilizing resources. So that is an area where, again, we have a lot of work to do, and sensitizing the countries, because pandemic fund is largely driven, proposals are largely driven by the ministries of health in that sense, and that's my experience so far. So I think that is one area, identifying pandemic fund opportunities and fragile conflict settings. Already we know there are a lot of humanitarian actors, there are already a lot of funding agencies in place because it's already in a fragile setting. So how we can incorporate some of the AMR elements into what the funds that they are already bringing into that space is something important. I mean, it involves smaller things, maybe in the primary care, ensuring antibiotics are appropriately available. So that's one area, and making sure that there are at least some level of care where there's a laboratory system in place. For example, I would recollect one of the recent things that we have done in two of the fragile countries in our region. We mobilize resources from a Wellcome Trust funded program, which helps countries to develop their own lab information management systems. So it actually enhances the quality of surveillance data. It helps to identify the resistance pattern, which actually help us as a tool to advocate more for more resources, either within from other agencies or within the existing governments or structures in the country. So I think these are two important considerations. One is use existing resources and other potential opportunities to mobilize from opportunities like pandemic fund, for example.
Okay. Thank you, Dr. Shafi. Now we have a question in our Q&A from an anonymous. Kindly put down your name as well at the end of the question so that we can acknowledge you. So the question is this: I was hoping to see the aspect on equity emphasized in funding strategies, especially given the nationalism lens and right-wing leadership that has engulfed global health financing in the background of the fact that most financing comes from developed countries, meaning the focus will be on developed countries' priorities at the expense of developing countries' priorities. What is your take, and how does WHO or the larger UN system plan to mitigate this?
Thank you so much. Again, it's an interesting question which I may not have immediate answers for the solutions, but what I would say is that what is happening in this space currently, of course, there are a lot of negativities, and we know the big countries which were supposed to continue supporting have backed. But we also know that there is a global solidarity when it comes to issues around AMR. Maybe it is not just because of to do something good in that sense, but also we know that AMR knows no boundaries. So, for example, there are efforts by several countries which actually look into the patterns of emergence of new resistance. So again, the priorities may be decided based on what the donor agencies or donor countries would like to achieve at the end of the day. But indirectly, these investments have supported countries establishing their surveillance systems, for example, identifying or bringing in treatments which were not available in those countries before. We have seen that happening in drug-resistant TBs. We are seeing that at least in certain drug-resistant infections in the general bacterial infections recently. So I think, bringing or strengthening regional institutions is one of the big steps that the low middle income countries can take to mitigate this effect. This I believe is temporary. At least during that time period, I think the important thing is to uh, come together as regional entities, regional institutions. For example, the Africa CDC is doing a lot of work along with WHO. So, and there are mechanisms like, for example, pooled procurement mechanisms. For example, our regional directors, one of the flagship initiatives in the region is to encourage and support pooled procurement mechanisms. So we work with models and other WHO regions. For example, PAHO is supporting our region in pooled procurement of vaccines. So there are opportunities to increase efficiency so that we get a better return of investment from whatever resources we have. But for that, I think the leadership of regional institutions matters a lot. And again, I would emphasize the role of Africa CDC in doing some of this really commendable work. One more thing, there are a lot of countries in the global south which are already doing a lot of work in terms of manufacturing and producing consumables and antibiotics required in AMR, and including and also vaccines these days. So the thing that we should do is to encourage such countries and support those countries and bring together the countries which are in require for such institutions to enabling to bring to create an enabling environment for pooled procurement systems to work. I think that is we are seeing some good signs now. For example, Egypt has been able to provide very specific products to a large number of countries which are affected by hepatitis, for example. We are seeing a lot of manufacturing of vaccines and other antimicrobials happening in Egypt and Pakistan recently. So I think that pooling the resources and bringing in efficiencies, but we need coordinated efforts by regional institutions to make this materialize.
Thank you, Dr. Shafi. I think we can take one more question to Dr. Shafi, and it is from Dr. Salman from React. This is about sustainability. Many AMR initiatives begin with donor support, but sustainability is often a challenge once funding ends. What strategies can help align donor investments with country ownership so that financing continues beyond the project period?
Again, thank you so much for the question. I think we had a lot of learnings from programs like TB and HIV over the last 30, 40 years, where this has been a constant phenomenon. When the donors move out, it creates a vacuum. So one of the things, again, the institutional strengthening, and again, I emphasize the importance of institutions which are member state driven in the regions to take ownership of sustainability. So as you have seen in my slide, I think in one of the slides I mentioned, one is to have very good implementation science and piloting before we scale up interventions. So that is one thing. So that implementation science enable us to understand how this will fit in the bigger picture in terms of the health systems, understanding the resilience of the system and how it can take it forward even after the funding landscape changes. Second thing is to identify partners and networks and a coordination of these institutions in the long run. Because, for example, I can take one example of MSF operations in many part of the world. The way MSF operates, and there are several other institutions for that matter, is that they embed the programs within health system. You train your public health system staff as soon as you start with the implementation of your projects. So any sort of a long-term plan for sustainability should consider capacity building of healthcare workers and program managers within the public health institutions, including capacity to identify and mobilize resources in the long run. I think that is very critical. Second thing is to transfer of knowledge. Transfer of knowledge to the local partner institutions, and as I mentioned, creating that network of institutions to ensure sustainability. We have seen such that things happening in several countries. Even during this crisis, we have seen like how countries which had such networks and systems in place were not severely affected compared to countries which could not do that. I think these are important things to be considered.
Thank you, Dr. Shafi. And I think we could have gone on with this Q&A, but unfortunately, due to time constraint, I'm going to stop here. So I would like to thank Dr. Shafi on behalf of React Africa. It was really a very insightful presentation and the session after that. Now moving on. Um, we'll now move on to our panel discussion. We have a very revered experts for our panel today. And let me give a brief introduction of our panelists but the detailed bio is available in the chat box. We have today Professor Mirfin Mupuntu, Dr. Nyambura Moremi, and Injida Indili. Now, Professor Mirfin, as you all know, is a global health leader with over 25 years of experience in antimicrobial resistance and public health policy. As co-founder and executive director of React Africa, he has shaped AMR policy framework, mobilized funding for LMIC health programs, and advised global bodies, including the World Bank, WHO, and USAID. A passionate advocate for One Health, he has presented at the UN and also World Health Assembly and global AMR summits. Our next panelist is Dr. Nyambura Moremi. She's a clinical microbiologist and technical officer at Africa CDC with over 14 years of experience in clinical practice, infectious disease surveillance, and laboratory system strengthening. She has played key roles in national, regional, and global AMR initiatives, including serving as Tanzania's principal investigator for the MAP study and regional coordinator for the Odin project on environmental surveillance. Formerly director of Tanzania National Public Health Laboratory, she has contributed to multi-sectoral AMR coordination and authored over 60 peer-reviewed publications. Injide Indili is a Nigeria country director for Farm Access, where she leads efforts to leverage digital technology to strengthen health markets across sub-Saharan Africa. She also serves as president of the Healthcare Federation of Nigeria and is a founding member of the Digital Transformation for Health Lab, advancing innovations for universal health coverage. With advanced degrees in health economics, management, and finance, Njide brings deep expertise at the intersection of health systems, technology, and policy. Now, moving on to the panel discussion as such, let me start with my mentor and boss, Professor Mirfin Mupuntu. Professor Mirfin, based on your years of exposure in this field, what are the most promising global financing mechanisms for AMR, and how can they be made more accessible to low and middle income countries? Over to you, Professor Mirfin.
Thank you so much for this captivating session, and thank you for the last presenter who made an excellent presentation. I think in response to your question, I think I would begin by really saying that we are discussing AMR financing at a time when global aid is shrinking dramatically. In 2025 alone, the United States cut 60 billion, hurting almost 90% of USAID contracts. The UK has reduced aid to 0.3 of its GNI, the lowest level in 25 years. Germany, France, the EU, Canada, and others have also introduced actually deep cuts. These implications are serious. In 2024, 12.7 billion of US foreign aid went to to access sub-Saharan Africa, and now up to 4 million additional people could die from treatable diseases because of these reductions. And at the same time, the economic burden of AMR is staggering. It already adds around 66 billion annually to healthcare costs. And under a business as usual scenario, this will rise to about 159 billion per year by 2050. And Africa alone faces over 1 million AMR deaths each year, projected to reach around 4 million by 2050. So yet the continent's financing gap is between 2 to 6 billion annually. And current funding for AMR in Africa is just 200 million, which is 10 times lower than we see in funding for malaria, TB, or HIV, but despite AMR causing a higher death burden. It's important to stress that AMR financing is not just a cost, it's a high value investment. And for every dollar that we invest in AMR interventions, the global return is estimated between $7 and $13. And so, effective AMR containment, could yield up to 80, up to around 88% annual return on investments, with potential global savings of 7.7 trillion healthcare and productivity by 2050. So the real question really is, with the traditional bilateral shrinking, what global financing mechanism can actually step up to fill the widening gap? A couple of these were mentioned earlier in the conversation. One of them is really adapting existing global health platforms. We do not need to actually start really from the scratch. Successful global mechanisms already exist, the Global Fund, Gavi, and Pandemic Fund. Each of these has demonstrated how large-scale financing can be mobilized and dispersed equitably. And the opportunity is to integrate AMR into these portfolios by funding stewardship programs, diagnostics, surveillance, and equitable access to antibiotics, much like vaccines or HIV medicines. We can be able to leverage on global solidarity levies and earmarked financing. And one powerful example comes from really South Korea, where $1 air ticket levy on every international flight is channeled into the global disease education fund. And so, one can imagine that, if we introduced $1 on all the international flights, we'll be able to mobilize actually quite a substantial amount. And thirdly, a global AMR trust fund is a way to go. Another promising mechanisms would be to leverage and establish these pooled resources and finances. And fourthly, we can look at outcome-based financing at the global level, developmental impact bonds, and other outcome-based instruments have been they've been used and tested in poverty and health programs, especially in low and middle income countries, and they have shown impact to that degree. But even the best of global mechanisms are going to fail unless they are designed to work for low and middle income countries. And there was actually a question, one of the participants that asked the critical questions on actually equitability of what. So I think these are some of the ways that we can actually ensure accessibility of these resources. One is that they have to be equity-based allocation formulas, and so that funding is distributed according to AMR burden and fragility and not on donor priorities. And secondly, we have to simplify the application processes, and so that low and middle income countries can access funds without bureaucratic delays. And thirdly, alignment with national AMR action plans, ensuring that funds strengthen country priorities rather than creating parallel systems. And lastly, inclusion of civil society is key, and communities to hold funders accountable and ensure that financing addresses real local needs. So in short, the traditional with traditional aid shrinking, while the AMR burden is rising, the world must turn to innovative global financing mechanisms to actually address these gaps that are quite evident. And I think adapting existing platforms like a global fund, pandemic fund, and creating solidarity levies, establishing a global AMR trust fund, and and exploring, outcome-based financing. All these are viable solutions that we can actually adopt. Thank you.
Thank you, Professor Mirfin, for those valuable insights. Um, uh, Taking note from what Professor Mirfin has just said, I will direct my next question to Ms. Ninjide Indili. I just want to say one thing to the participants. Please put down your questions in the Q&A. We will be taking those questions in the end. But let's complete the panel questions first, and then we will move on to the Q&A in the end. So moving on to Injide Indili. No, from what Professor Mirfin has just mentioned, it's very obvious that donor fatigue is a concern across health areas, and also the changing funding landscape that we are in right now. In this situation where there are other competing priorities, how do we ensure AMR remains a priority and financial pledges are translated into real interventions on the ground?
Okay, thank you so much for having me. I've been listening quite intently. And sometimes I often wonder why, yes, there are lots of problems in the healthcare sector, but we tend to, focus solely on particular disease ailments, no matter how important it is. And that tends to fragment the healthcare system. So, I think one of the most important actions that we should take now that there's reducing donor funding is how do we make AMR cross-cutting? I'm sitting on the Global Futures Council for AMR with the World Economic Forum. There is a convening coming up in October, I think October 14th to the 16th. And initially, when I was invited, I'm like, okay, why am I being invited to an AMR discussion? Initially, I didn't even respond. So eventually, they requested for a one-on-one discussion with me. And their particular interest in why they wanted me there was more from a system strengthening point of view. From the fact that now that donor funding is diminishing, how do you make diseases and issues we have in the health sector cross-cutting? I think it becomes very important because we often work in silos. We look for funding for specific programs, vertical programs. And for me, and the work that I've done over the last decade is how do we begin to horizontalize vertical programs? So for AMR, how do we make it a cross-cutting issue? How do we make it not a lab issue, but how do we integrate it into cancer care, maternal care, emergency care, and so on and so forth? I think that's one priority area that we have to keep it at the front burner of political priority in terms of making it a cross-cutting issue. Then how do we broaden the financing base? That's also another thing. Innovative financing mechanism, private sector engagement. I happen to be the president of the Healthcare Federation of Nigeria, which is a coalition of all private healthcare associations trying to work with government to strengthen the healthcare system. Often, it's documented that over 60% of care in the healthcare sector is provided by private sector. And I can tell you that really, AMR is not even high on our agenda. Nobody's talking about EMR per se within the private sector, yet we are the ones delivering care. So how do we engage private sector? I think that's a very important discussion that needs to be had. The pharma, the diagnostic, how do we ensure pay for performance maybe? How do we ensure that, within the national health insurance benefit packages and the schemes, like we have in Nigeria now, we have the National Health Insurance Authority. We have laws that have been adopted across all 36 states, making health insurance mandatory. How do we ensure that there's some kind of monitoring within those that are implementing the insurance packages? I think this is something that we need to do to broaden that base so that it's not really how do we raise funding for AMR, but rather how do we, within the National Health Insurance Benefit Package or the Basic Healthcare Provision Fund within the country, ensure that AMR interventions are monitored and maybe some kind of pay for performance integrated there. Then another thing is, how do we keep it visible? We're not even hearing stories of patients who have had adverse events or even narratives from civil society that this is actually a case that we need to, bring to the fore. I'm currently writing an op-ed on AMR, why policy needs to be fast-tracked and the integration of private sector. Again, why am I writing this op-ed? Because next year, Nigeria is going to host the Ministerial Summit on AMR. And really, I can tell you that the country is not really aware. I don't know that it's a priority. We have the National Center for Disease Control. They are taking action on the national policies, and they're doing some interventions. But again, funding is low, and I'm not quite sure how much of that has trickled down. So we need to find a way to aggregate the efforts that are being made, highlight it through patient voices, find a way to integrate it into already existing national programs for UHC instead of finding a separate track to focus on AMR by itself. And really, how do we ensure that we translate the money into action? Where all sorts of funds being raised all over the continent of Africa. But in terms of direct impact and output, I think it's yet to be seen. Are we documenting that? Are we investing in the people, implementation capacity, scalable pilots? I mean, you name it. So there's quite a bit going on where we can find a way to integrate and kind of stretch out the limited available funding that we have to have the most impact to tackle the AMR problem. But most important is that AMR shouldn't be looked at as a singular problem, but rather how do we integrate it into the advancement of UHC, access to better healthcare. I think that will go a long way to leveraging the funding that is already existing.
Thank you, Njide, for those valuable observations. As you have rightly pointed out, many a times the funding is like disease oriented and also it is donor specific. But as you have rightly pointed out, that AMR is not, it's a cross-cutting issue. And, considering the fact that Nigeria is one of the African countries who have or that have, earmarked at least a specific amount for AMR, whether it is actually trickling down, it's like a very valuable observation. And again, I'm sorry to trouble you. I'm just continuing in that flow. The next question also, I'm just directing it towards you. Considering your experience working with in private sector, do you have any tangible experiences or that you can share where the public-private partnerships have worked in health financing and how these lessons could be adapted to AMR?
Okay, so I have two examples. I'll talk about the first one. This is a tool that we call the mobile application for TB screening. This is now for TB, right? So somehow we can relate it to AMR down the line. So Nigeria is one of the countries with the least detection of TB cases, right? And what did we do in partnership with the Global Fund? We said to Global Fund, look, you guys invest a lot of money in Nigeria, buying commodities, buying just bricks and mortar tangible things. Why don't we help you as Farm Access Foundation develop an algorithm which we can put in the feature phones and also smartphones and disseminate it into the community? Because that is really because of stigmatization, people don't want to go into the hospitals. So how do we leverage the community health workers? Now, we did this in partnership with Global Fund. The funding came from Global Fund, but we involved the National TB Program, which is charged really with solving this problem. Then the Institute of Human Virology, which was also part of it. So we really programmed, it's just a simple algorithm. Are you coughing? How long have you been coughing? There's a series of questions. And when the questions are answered, it gives you a score and tells you whether you're TB presumptive or not, and then triages you to a specific lab within that area where you can then get tested if you have TB or not. And then from there, the treatment starts, or you get some counseling. Now, when we started this, we started in one state. And I can tell you that 4 years after, which is now, we as Farm Access are totally out of the program. What we're doing now is research and documenting, the impact evaluation. But it's been adopted in all 36 states in the country, right? To the extent that now the problem is we don't have enough hospitals where we can treat the patients that we're identifying. So that is a typical PPP, where we start with, you start private, you start, a small pilot, but ensuring that government is involved or the regulator involved, and then there's a scaling partner. This is a model that can be tested. So that's one. On the financing side, this is something we've done in Kenya, in partnership with MTIBA. Well, it's called MTIBA, but it's Farm Access in partnership with M-Pesa, where you have a mobile wallet. The wallet enables you to access care, can go to the lab and be able to pay for services through funding that has been put in your wallet. But we track that funding and we can direct you and also be able to pay the provider. So through that, we can monitor and triage so that people can access the right care in centers that have been either quality assured. We ensure that you can only use that funding for specific services, payment of specific services. So that way you can really monitor. So there are quite a number of examples, but these are the two that come up very, very frequently, as opposed to, doing it by yourself as government or private sector doing it in silo and not even involving government, but to ensure that there's some kind of handshake where the government knows what is happening in the private sector so that they're better able to put in place solutions or mitigants to capture what is happening within the disease-specific environment. I hope that helps answer. But a lot of this is online, so you can actually look at it. The maths tool right now has screened over 4 million people in the last 3 years. So it's huge, it's massive. And now it's disseminated to, community health workers. You don't have to go into the clinic to get tested, so the stigma goes away. So these are some of the things that we need to begin to look to adopt, especially where health insurance is very low. That means that people would generally go and self-medicate because they can't afford to go into the hospital to get proper diagnosis. So I think it's something that needs to be looked at to see if there's a way to replicate it across Africa. Over.
Thank you. Thank you for sharing those examples. They are very informative. And I must also say that React Africa is doing not something to do, I mean, something similar to using this digital technology. So I guess, a greater or deeper discussion in this regard between React Africa and you will be very, very helpful in terms of how we can expand this in terms of in the context of AMR. Now let's move on to our next panelist, Dr. Nyambura. Dr. Nyambura, could you share with us some of the emerging innovative regional or domestic financing solutions, and how can we scale them?
Thank you very much, Sherwin. So very insightful discussion are going on here. So thank you to previous presenters. I would like to take you a bit back when we were having the presentation from Dr. Koya. regarding the tracking AMR country self-assessment survey of last year, the last year report, 2023-2024, which highlighted that only 25% of the national action plans are costed. More than 80% of countries globally have developed their national action plan, but only a quarter, they are costed and budgeted. What does this mean? That means as much as we talk and advocate for the financing of AMR, we should also look at this particular angle where countries are not ready. Why am I saying they're not ready? Because if you have a non-costed and budgeted a plan, that means you are still talking of just policy statements. There is no like implementation roadmap which you have to. So those plans cannot be used, for instance, to mobilize resources. That means they cannot be funded, they cannot be implemented, as well as no one can monitor the activities that you are doing and take accountability of the funding or the investment that is being put there. At Africa CDC, just 5 months ago, around April 2025, we launched a continental-wide strategy, transforming health financing and advancing self-reliance. The main or the core of this strategy is just to advocate for sustainable domestic financing, to help member states and advocate for sustainable domestic financing, how they can embrace the innovation as we take recognition also of our global champion of health financing, President Kagame, has demonstrated very well the successes of the community-based insurance scheme. So how can we leverage, as Professor Miffin was saying, those solidarity levies? The African even philanthropists. We are used to see a lot of global philanthropists, but in Africa, this can also be done. How are we leveraging on those? I'm aware of some of the African countries that have mobile phones, solidarity levy. Some are even about to introduce the ticketing as Korea is doing. But how can we ensure now our AMR agenda is being slotted in whatever percentage that can be gathered there? On the public-private partnership, previous speakers have really deep dived on this. But again, I would like to insist that it's high time also with these funding cuts, we leverage on diagnostic and pharma industry to finance or to co-finance the AMR interventions. How can the public sector put those policy framework incentives that are like friendly for the pharma industry or the diagnostic industry, as well as private institutions, for them to leverage and expand services at a cost which is accessible and affordable to the majority. Again, I like the idea, the point from Dr. Koya when he spoke about how can we, again, leverage these grants and make sure like they reach, or they cater for a big portion of the people we serve. So for instance, at the regional level, I'm aware that EXA-HC, as well as ECOWAS, have been implementing programs from World Bank funded projects, as well as other funding. But if you look at them, like they try to group countries with the same needs and whatever. So they go like multi-country approach. At Africa CDC also, we have been supporting countries over the years, the member states, but some of the intervention have been at country levels, like developing plans, policies, and all other documents that are essential in AMR intervention. But now with the funding cuts, how can we leverage the funding that we have, the little that we have, but at least to make sure that our intervention go wider. So those are like the multi-country approach, I think, or regional approach is the best way to go again. Last but not least, We recognize efforts that are made by our parliamentarians. How do we involve legislative? Let us not forget that parliamentarians are the custodian of national budgets in terms of approvals and allocation. And they have power, actually. In most of the countries, they have the so-called, they can ring fence some of the funding. But for them to do that, we need to engage them. We need to let them understand, as Njide was saying, like we need to let them understand so that they can advocate for our AMR agenda. And in this, I would like also to acknowledge some of the countries, for instance, Zambia, Uganda, and Tanzania have the alliances or association. They are really actively engaging the parliamentarians. It's high time because there are a lot of competitive priorities, even in health. So it's high time also to leverage on these use cases to expand this awareness and make them like understand. Once they understand, they will advocate for these budget lines at the national level, and will be at least better placed to thrive within this transition from the donor-driven like intervention to domestic financing. Thank you, and over.
Thank you, Dr. Nyampura. And as you have rightly mentioned, parliamentarians play a very key role. And in our engagement, React Africa's engagement with parliamentarians, it's a wake-up call that we stress more on financing aspect as well while we are engaging them. I'm quite mindful of the time, but before going into the Q&A, one last question to Professor Mirfin. This is regarding this is related to equity and accountability. So, Professor Mirfin, how do we ensure resources are distributed equitably and that funding commitments are tracked transparently? Over to you.
Equity and accountability are at the heart of AMR financing, actually. And I think the conversation, so far does underscore that. I think the burden of AMR is not even shared itself. Africa accounted for 22% of global AMR deaths in 2019. That's projected, as I earlier said, to about 40% by 2050, meaning 4 million people deaths will occur actually annually. And yet AMR financing in Africa is only around 200 million a year, when we need between 2 to 6 billion every year in terms of investments. At the core of it, though, is with the pooled funding and the pooled resources that are available or that could be mobilized. How would we ensure, equitable distribution of resources? I think one of the things that we have to do is that we have to develop, equity-based allocation formulas, and so that resources should be distributed based on the AMR burden, on fragility and vulnerability, rather than on the donor priorities or political visibility. For example, fragile and conflicted affected states, marginalized populations, and high burden low and middle income countries should be prioritized in financing frameworks rather than countries that do not fall in these sort of margins. And secondly, there has to be targeting undeserved populations, and so financing must explicitly include refugees, displaced people, rural communities, and those excluded from the formal health systems. Without equity safeguards, AMR investments risk reinforcing existing inequalities in access and antibiotic diagnostics. We have to integrate these mechanisms into UHC and primary healthcare. Equity is not just about who gets funding, but also it is how it is used. And so embedding AMR into universal health coverage packages ensures it reaches communities through primary care and not just tertiary hospitals. Dr. Ndije had talked about the integration into broader health systems, and I think that is that is a way of ensuring the equitable distribution of resources. But in terms of accountability and transparency, we should be able to track the pledges and disbursements. Many global health areas like HIV, TB, and malaria, they use scorecards and dashboards to compare pledges versus the actual disbursements. And so AMR needs a similar accountability too that really tracks what is pledged and what is actually dispersed. And I mean, AMR, our Global Financing Observatory, possibly hosted by WHO or the Africa Union, could track the donor and domestic commitments. And secondly, independent monitoring would be critical. And so independent bodies such as universities, regional network, civil society, coalitions can audit whether funds are being spent as promised. This prevents the paper commitments that never translate into impact on the ground. Thirdly, community and civil service oversight. Really, civil society plays a role as watchdogs. And so in HIV Community Network, they successfully held governments accountable and donors accountable for, delivering on promises. And we also have to have mechanisms that hold our governments accountable. Most of our low and middle income countries, especially here in Africa, we talk about actually the COVID funds, for example, that came in. How much of those leaked out of the system? Almost every single day, you read a paper in one of the countries around health, funds from the health sector that have leaked out of the system, that are missing, that have been misused. And we don't see any of those folks held accountable. And so, that accountability, has to be there. But also, we should be able to develop and build digital transparency tools, online dashboard, open data platforms can make funding flows visible in real time and building the trust between the governments, the donors, and the citizens. And so to ensure AMI financing delivers results, we need two things. Equity accountability. Equity means resources are allocated where the burden is highest and the needs are the greatest. And accountability means that every dollar pledged is tracked, disbursed and monitored transparently within civil society and communities as part of the process. Without these safeguards, AMI financial risks become another cycle of unmet promises. With them, we can ensure resources translate into a real impact on the ground where they are needed the most. Thank you.
Thank you, Professor Mirfin, for stressing the need for follow-up, whether it is funding, whether it is implementation, to ensure the accountability aspect. Now, moving on, this is the time to ask questions to the panelists by the participants. We already have two questions from one participant named Venus. It is not specifically directed towards any specific panelist. Let me read out the first one. Considering the current shift in funding landscape, should we not look more into domestic funding models for AMR? Should I take both the questions together, or I think both goes hand in hand. So I think I'll read out the second part as well. Should we not consider strengthening the components of AMR in infection prevention and control, laboratory systems and pharmacovigilance, health workforce, etc., which are already huge components of the pandemic fund, global fund, and other funded programs, as AMR is cross-cutting? AMR seems to have been positioned as a silo program, and do you think it is still possible to to consider a shift in the approach? So probably I'll start with Njide Ndili, because you were already talking about, we should move away from the silo approach. So over to you.
Yeah, for sure. I mean, I was smiling because that is exactly what I was talking about. I mean, we don't have a choice in the matter. But having said that, I think the best thing we need to do is to align incentives. How do the contracts reward stewardship and rational use of antibiotics, things like that? How do we ensure that within the benefit packages of health insurance programs, that there's, stewardship embedded and so on? How do we ensure, that PPPs, public-private partnership, builds on accountability? How do we measure performance? How do we ensure, that, there's some kind of blended financing where government brings its funding, available donors can still bring their funding, private capital. So basically, in a nutshell, which is what I preach, is that we cannot do this. We can't treat AMR in silo. I know it's a silent pandemic right now, but we have to find a way to make sure it's integrated into the approach to UHC. Otherwise, we will keep working in silos, replicating efforts, and we are always talking to the same donors and people anyway. So why don't we aggregate the effort and deal with it once and for all? So for me, is aligning or horizontalizing all these vertical programs. Not that one is not more urgent than the other, but to find a way to have them integrated and have a unified approach to the solutions that we're seeking. Over.
Next question is to Professor Mirfin. This is from Erastus Injorhe. I'm really sorry if I'm mispronouncing your name. Prof, this is the question to you. You mentioned tools for accountability. Who do you think should step up with creating the tools and the incentives?
Yes, so I think that's an important question, and I think it's quite key. And I think the way that I would look at that is that the tools should be developed by the bodies that have got the mandate. And in this case, we do have the quadripartite. They do have the mandate for for AMR implementation. They do have the mandate in monitoring the multi-party trust fund. But that should not end at that. These should be inclusive. They should be developed in collaboration with governments, with civil society, with other interest groups
avec
to
notre
actually
groupe
ensure
d'intérêt pour assurer que
the principles
les
of equity,
principes
the principles of accountability
d'équité et de
are actually
redevabilité
built
soient
in, and that these
vraiment
tools they
renforcés.
have the credence and they can be trusted, they can be believed in. If they are only developed by the entities that that are not inclusive, they will not be trusted, and there will not be instruments that are going to attract any sort of validity, and they essentially will not be trusted. And so these tools have to be developed by not just one single body, but by actually by involving key sectors and key stakeholders in the development of these tools.
Thank you, Prof. Now, before taking the next question from Tracy from React, let me just expand the question from Venus. That is, he was already talking about how should we not look into the domestic funding model. So I'll direct this question to Dr. Nyambura. Dr. Nyambura, what are the key challenges in just looking at domestic funding models alone? Is it possible when it comes to something like AMR to address it with the domestic funding, especially in an African context? Dr. Nyambura?
Thank you, Sharon. for expanding the question and making it not so easy, not so easy to respond to. But so the keyword there is alone. As much as we advocate for domestic financing, the sustainable domestic financing, for us to reach the sustainability, that doesn't mean that that alone can be sufficient. And remember, like we are coming from a point where I can say we are kind of relaxed. Maybe relaxed might not be a better word, but we are kind of relaxed and just implementing in most of the cases, the donor-driven interests. Yeah, so as we transition, that's why we are trying to leverage on different models. So domestic financing is one, and as we have discussed, some innovative ideas that we can use to at least to sustain the interventions. But again, also that's why we have also said, like, as we leverage on the available global funding, we need also to take accountability of them. And as well as Professor Mithipin has said it very well, that equity, we really need to take care of those with high burdens. Like we cannot like have a one size fits all. So we need to prioritize and make sure like that cake that is available globally, like we are using it in a steward manner, as well as also integrating that AMR program, as Jide was saying, rightly saying, into our horizontal programs. So domestic financing alone as a keyword, I can't say like, yeah, we'll reach there, but our aim is to reach there. Like, that's why we are advocating for sustainable domestic financing. Thank you.
Thank you, Dr. Nyambura, for addressing it quite well. Now, moving on to again the question from Tracy from React. This is again to Professor Mirfin. Does the SDG Voluntary National Review offer a platform for reporting, especially AMR financial expenditure, in a transparent and accountable manner by member states, at least as a start?
That's excellent, and it's actually a very good start. I think the voluntary national review for SDGs provide a forum or provide a platform and a way in which countries can self-evaluate and can self-report. That's a good start. But I think I would go a little bit further that, I think whereas that's a good start. I think probably a better framework would include what we see in the international health regulations, where we see external validation occur by independent member countries and independent intergovernmental organizations that come for the validation. And so, yes, the VNR is a very good start, but I would add on, I think, a component of external validation, like we have with international health regulations, as a means of, validating what the country is actually reporting to be true and to be accurate and to be believable, also to attract more financing and to attract more investments to that end. Thank you.
Thank you, Prof. There is a comment towards Dr. Nyambura from Jackson Silincha. Good presentation, and all in all, key sectors should be involved and coming up with significant equity financing model. So that any more questions? If we'll wait for 1 more minute if you want to post any more questions.
Or even comments or insights or anything that spoke to you as an attendee.
Yes. So we are almost reaching towards the end of our session today. It's already 5:25 my time. Like we have 5 minutes more. So now that we don't have any more questions, let me thank all our panelists and participants for such a rich discussion. What we have heard today reinforces that financing AMR is not just a technical challenge, but a political and economic one. And plans without resources will remain fragile. And unless we move decisively from pledges to actual allocation, the global south risks being left behind. So let us keep this conversation going and keep pushing towards sustainable, equitable financing that will ensure AMR action is not only planned but delivered where it matters the most. And thank you once again. And let me now hand over to Mitupa.
I think you've already done a great job at summing up our discussion. Just to thank our panelists and speakers once more for taking the time out to discuss this very pertinent issue. Your insights have all been extremely valuable, and we really appreciate you taking the time. And for our attendees, thank you for your attention. Thank you for your questions and appreciation as well. Thank you, everyone.
Thank you very much for having us.
Thank you very much for having
Thank you.
me. All right,
Thank
bye.
you. Bye. Bye.